I'm Dr. Suchanda and I'm the moderator for this evening. And we have a great panel and two great eminent speakers from the world and from the East as well as the West. And I really thank them for being with us at the odd hours because in Japan it's around 8:30 p.m. and in USA it's 7 a.m. And so it's almost extreme of time, but still they devoted the time for this webinar session for the Indian Society of Pediatric Neurosurgery. And Dr. Deepak and Dr. Sandeep will be joining little late, who are the presidents and secretary respectively. In the meantime, without any delay, we will start. So today we have two speakers. One from Japan, as I said, he is from Hiroshima University, Professor Koji Ida. Dr. Ida is a great name in epilepsy surgery. He is the head of epilepsy center over there, and he has numerous publications on epilepsy surgery. Professor Ida has actually a lot of interest in electrophysiology and EEG. I mean, we neurosurgeons, we actually don't know much about EEG, though we call ourselves epilepsy. And he has a lot of papers even on that. And so we are fortunate to have him. And the best thing is that he runs courses for all the, EEG people who learn EEG, like the technologists, the paramedical staffs, and all in Japan. And I'm told that is a big success. So we are glad to have you here, Dr. Ida. I know you have another talk early in the morning also to be given, but in spite of that, you have devoted time for us. We are very happy to have you here. We will start with your talk, but before that, I would like to introduce Professor George Jello, our second speaker. He is from Johns Hopkins University. He is a professor of neurosurgery and director of the Pediatric Neurosurgery Center at Johns Hopkins University School of Medicine. And he has a lot of interest in not only epilepsy surgery, but also in difficult pediatric things like the brainstem tumors, spinal tumors, and all. And he has his own lab where he does researches on all these things. And his lab, I'm told, is first of its kind in the USA, where all these studies and researches are going on. And he leads a team of neurosurgeons, neurologists, psychiatrists, psychologists, developmental pediatricians. And he has published, besides his numerous papers, which both of them have numerous papers, he has two very good books on pediatric epilepsy surgery, and they are like the always the reference textbooks for all of us who practice pediatric epilepsy surgery. And they give us a whole insight of what is going on, the current status. The recent book was published in 2019, and we managed to get him, and he has readily accepted our offer to come and to do this webinar even after a holiday which was there yesterday. And these are the two speakers, and we will hear him after Professor Ida. And after that, we have a set of three very great panelists, and one is Professor Manas Panigrahi. In the Indian circuit, everyone knows him. I don't think so I need to introduce much about him. He not only excels in epilepsy surgery, but I think in every surgery, every forum, everyone wants him. So he's always there in either this society or that society's webinars. And he has done almost 1,000 epilepsy surgeries and also has a good publication on epilepsy surgery. And we are glad to have him here. Next, we have Dr. Jabin, who is a neurologist with whom I work closely. She's from an additional professor from the Zamsi Institute of Medical Sciences, and she's a very, a very devoted epileptologist, because our institute is an institute we can define by a resource poor institute, and so we cannot afford the luxury of all the invasive monitoring and all, but we all depend on the clinical acumen of Dr. Jabin, and she really does it well. And it takes a little bit of time for us to get everything in order, but our failures are and successes, and I should say that we are happy with our results. And I think the biggest credit goes to Dr. Jabin, because she works so meticulously in bringing the correct indications for the cases before I put my knife on them. And the next panelist we have is Dr. George. a very good friend of mine. He's an additional professor at Sri Chitra Tirunal Institute, Kerala, Trivandrum, and he does epilepsy surgery, and he works in a center from where actually I also got trained for epilepsy surgery, and he has helped me to learn epilepsy surgery as well. And Dr. George also does a huge number of epilepsy surgery, the other things which goes on in as a routine neurosurgeon. So we are glad to have all you panelists and all the speakers. And without further delay, we will start now with Professor Koji Ida's talk, and we are eager to hear him because he will talk on intracranial monitoring. And over to you, Professor Ida, and you can share your screen now.
Okay, can you hear me?
Yes, we can, Professor Ida.
Okay, so let me start my presentation. And let me share the image.
Yeah, we can see.
Can you see my slide?
Yes.
Can you see my slide?
Yeah, we can see.
Okay, so I'd like to start my presentation right now. And thank you for everybody. So good evening. Here is now evening. And I'd like to talk about the recording ingenuity for intracranial EEG monitoring in pediatric patients with intractable epilepsy. And at many centers, stereo EEG is rapidly expanding in practice. It's often replacing a surface-based ECOG, for example, chronic intracranial EEG. But in Japan, still intracranial video EEG is surface-based. IVEG is most often used to determine the localization of site. And compared to adult situation, special care should be taken to implantation and the post-implanted general management, particularly for epilepsy pediatric patient. And I think at least three aspects required for to take into consideration. The first is requirement of extended grid implantation. Be careful to fix of the bone during operation and to avoid brain compression by grid electrodes. We need ingenuity for dural and cranial plastic. And the second is a post-implanted general management. The patient the children may have serious problem after surgery. So that's why we have to keep very, close contact to the children. And the third one is ingenuity during monitoring. How to keep the post-operative rest during the monitoring, and how about the feasibility of the functional mapping. And I'd like to show you the three pediatric patients with different ages. The first case is a 1-year-old 6 months boy. He was normally delivered. There was no history of febrile convulsion. After 2 months of age, at 2 months of age, his seizure started with twitching of the left eye and mouth and the left arm extension. At the 7 months, general tonic-clonic seizures has started. And the current seizures consisted in two types. One is atonic seizure in the left extremities. Another is the impaired consciousness with eyes deviation to the left. And even though the four antiepileptic drugs, his seizure was not controlled. And the seizure frequency was 2 and 3 times per day when he was referred to us. And his neurological finding was normal. This is the imaging. As you can see here, so this is the central sulcus, and just inside the motor cortex, the deep side, there was a lesion like here and here. And on the CT image, the lesion was calcified like this. Looks like cortical dysplasia or something like that. And imaging needle spect shows a low accumulation corresponding to the lesion. And FDG PET also showed the low metabolism corresponding to the region in the MRI. But compared to the left side, very extensive area of the right hemisphere showed the low metabolism in the on the FDG PET. And the MEG showed small clusters of the dipole, like here. In the right side, lower portion of the frontal and central region like this. It's not corresponding to the such a region. Little bit lower portion. And I'll show you the scalp video imaging monitoring result. And so here there was burst of the slow activity on the right side, temporal and central parietal region started. Then the patient head drop down like this. So we planned the surgical surgery. The seizure foci was suspected from the region and the surrounding area. And this is a 3-dimensional brain imaging. Here is the central sulcus, and this is the region in the deep side of the central motor cortex. And we need the IVEG with grid and depth electrode for precise localization and the functional mapping to preserve the eloquent cortex.
वो देखो खुजली कर रहे हैं
Sorry?
खुजली कर रहे क्या
Yeah. Professor Koji, please go ahead. I think it's some
नहीं
disturbance.
तो हाथ में लगा तेरे हाथ बहुत ठंडे हैं
Please
Okay.
go ahead. Don't worry.
For support, can you please mute yourself?
So our purpose is to estimate the pyramidal tract using a DTI, and from here to here, this is a pyramidal tract. And second is to identify the pyramidal tract using MEP. We plan to insert the 3 depth electrodes surrounding the region like this. And this is the planning of depth implantation and intraoperative stimulation. This is a region here and the pyramidal tract landing here. And we put we plan to insert the 3 electrodes like this. And when we do the operation, there was some ingenuity of the head fixation, depth electrode insertion guided by the navigation system. So in this patient, we used the 3 head pin to fix the head. But for pediatric patient, we shifted this kind of 3 head pin to a 4 head pin to avoid the to reduce the spring pressure, and we use a gel pad to support the head. And this is during the operation navigation system here. This is called as value guide. As we used this kind of the navigation system and inserted the depth electrode. This is the brain surface and the central sulcus by SEP. And from here, and here, we inserted the 3 depth electrode. And this is the motor cortex and the central cortex. And then after the implantation of the subdural grid electrode, and here, and this is the strip electrodes. We have the total 89 channels like this. And from here, the tip of the depth electrode 77, we obtain the motor response by the train of 5 MEP. So we can use this electrode as a functional mapping when we reject the lesion. At the ingenuity of, at the dural-plasty, we usually close, but not suture tightly. There should be plenty of the room of the dura to avoid the intracranial pressure increase. And when we fix the head bone, we do not fix them very tightly. It's very loosely sutured like this. Then after the surgery, we do the general management assisted by the neuropediatricians because the patient had the post-surgical tracheal edema. So that's why the neuropediatricians has a very strong assistant to keep this patient. Fluid replacement and the decision of the steroid administration. The IVEG was done for 3 days, and we had captured a total of the 23 seizures. There was no problem on the monitoring because the patient was supported by the bed frame and the parental cooperation was very strong. Very nice one, I think. But we cannot do the functional mapping because of the very young children. This is the result of the IVG, and gray circle was ictal onset by the visual inspection. We did frequency analysis, and the red circle shows the high frequency operation over the 50 Hertz around here. Then we decided resection with this area. This is a planning and depth electrode and the pyramidal tract, and this is the planning of the cortical resection. Finally, we did the resection, and this is the MRI after the surgery, and he had transient left hip paralysis, but recovered within 1 week. Seizure freedom was obtained for 2 years. And the second case was a 3-year and 3 months girl, and right-handed. She was also normally delivered. There was no history of febrile conversion. Infantile spasm started since 4 months of age. There are many treatment was done, but seizure control was not obtained. Currently, she showed the head drop followed by the bilateral arms. She showed slight hip paralysis on the left, and developmental delay was slight on the neurological examination. This is a preoperative MRI, which is showing very extensive focal cortical dysplasia, abnormal gyration on the right hemisphere, but the central region looks normal. And the patient has had a very slight hip paralysis. That's why we try to prevent cortical resection of the central region. And that's why we do the grid implantation like this. This is central sulcus. And also, we did the general management assisted by the neuropediatrician. And the IVEG was done for 4 days, and we captured total 20 seizures. Also, we could not do the functional mapping. The problem of this patient was difficulty in keeping rest during the monitoring. There was a requirement of parental dedicated cooperation. And this is a slide. What I want to show you is not the EEG, just a video. And there was a difficulty in keeping rest during IVEG. The children of this age is not standing still. She was very active. That's why the parent is always keeping the eyes on the patient. And during the night, the patient was, the parent, her mother, was always observed the patient. And finally, we decided to do the subtotal hemispherotomy like this. And this is the post-operative MRI. There was external fluid collection, but there's no problem. And this is a disconnection line. The seizure freedom was obtained for 1 year and 4 months. Her development was recovered and very well. And she showed the left paralysis, but now it's improved. The third one is 9-year-old and 9-year and 7-month girls, right-handedness. And I'd like to show you the MRI. So the seizure started 5 years. Tonic seizure developed after 8 years. But anyway, so this is the MRI preoperatively. Here you can see the cortical dysplasia in the right central region. This is the result of the MEG. We did the subdural grid implantation also, and this is a result of the functional mapping. And in this patient, there is no problem. No problem. This is the depth electrode. No problem on the grid implantation, IBG monitoring, and the functional mapping, like as an adult. So I would like to summarize these findings. In cases of infancy, 1 year and 3 years, we used a gel pad for head fixation. We do the avoidance of the strong cranioplasty. We do the management of the postoperative general condition, tracheal edema or fluid replacement in cooperation with a neuropediatrician. We could finish the EEG monitoring for a very short time, but in a 1-year-old boy, it was easy to keep rest during the monitoring, but very, very difficult in a 3-year-old girl. Parental cooperation required, particularly in 3-year-old girl. And SCP-MEP could be an alternative to functional mapping using subdural grids. In case of 9-year-old girl, she was very sensitive and cooperative. There was no problem on all procedures. So in conclusion, in the invasive EEG monitoring for children, the certain ingenuity is required to avoid specific complication. Post-surgical management should be assisted by neuropediatricians. Standard functional mapping using electrode stimulation is less feasible in infancy, and alternative method is required, like SCP or MEP. And parental cooperation and the possible short recording are essential for the safe recording, particularly in children difficult to keep rest. Thank you for your attention. That's all.
Thank you, Professor Ida.
Yeah.
It was a very good lucid talk, and almost very difficult to manage the vaccine period. But we will not take the discussion now. We will go to the second talk, and then together we will have the discussion on your talk as well as Professor Jello's talk. So I would request now Professor Jello to give his talk on the surgery of toddlers as well as infancy epilepsy surgery. So over to you, Professor Jello.
Thank you. I'm going to share my screen. Good morning, good afternoon, good evening. Professor, oh, great. Let me just see. Here it is. Hopefully you can see my screen now.
Yeah, we can.
Yes, we can.
Okay. Great. So I think when I talk, the talk I was going to give this morning or this afternoon is really on epilepsy surgery in infants and toddlers. And I think, just a little background, we all know that epilepsy it afflicts about 1% of the world's population, and that 20 to 30% will develop intractable epilepsy. The mortality is much higher in these children and adults than the general population. I think what we have to recognize is epilepsy is much more common in children than is reported, and that although 5% of the children will have some sort of seizure before age 20, fortunately 80% of them will not have another seizure. However, the remaining 20% will develop epilepsy that becomes refractory. And when we talk about refractory, it's really children that are on 2 or more medications and still continue to have seizures. When I looked at the prevalence of the disease, looking at North America, the United States, and Canada, Europe, as well as India, it's somewhere between 5 to 10 per 1,000 people. And what we do know is that surgery for temporal lobe epilepsy is very effective in adults, with seizure control rates around 60, 70%. However, only less than 2% of eligible patients, adults, undergo surgery in the United States. And I think there was also another New England journal that was recently published from Ames looking at the drug-resistant epilepsy in children. And they too found that the seizure control rate with surgery in children is close to 70% as compared to the medication-only route. So surgery in children is very effective. So why do the epilepsy surgery? I think you can eliminate decreased seizures, it can improve quality of life, and prevent neurological deficits. It's even more pronounced in children because these repetitive seizures and the anticonvulsants might inhibit brain development, hamper socialization, school achievements, and learning. And yet, as seen in our earlier presentation, the plasticity is superb. In those 2 representative cases, the children had some hemiparesis, and they did recover that following the operation, and they had seizure control. So I think, when you read this, there's this paper in 2016 that looked at the effects of seizure on the developing brain and cognition, and recommend everyone. Looking at this recent publication that was just published, the effectiveness of medical and surgical treatment for children with refractory epilepsy, and they looked at the Children's Hospital Association database in the United States. And what they were looking at is the children that underwent surgery versus the children that were managed medically, and they had a little over 4,000 cases, and they matched about 2,000 cases in each. And what they did find was that when they looked at all this, and narrowing it down to the 4,000, they found that the children that underwent surgery had 30 to 40% less admissions to the hospital and less complications as associated with those children that did not undergo surgery. So I think, clearly we've had several papers that show the benefit of surgery in children regardless of their age. And I think when we look at the paradigm for epilepsy surgery, if there's a lesion, resecting the lesion will be diagnostic, oncological, and there is a role for epilepsy. If there are multiple lesions and the goal is epilepsy surgery, such as tuberous sclerosis, really need to have a focal approach to resecting these, and that's where your depth electrodes and your grids will become helpful. And there's several papers from the NYU and Howard Weiner looking at multi-staged approach to these special lesions. And when there is no lesion, it's, diagnostics, as we heard earlier, can help identify a surgically electrical lesion, and that, that there is a role for the resection of this. If there's no lesion and no clear epilepsy, invasive monitoring, and in case we cannot find any surgical solutions, then we really can change from resections to some of the neuromodulation techniques and or disconnection procedures. And I think this is critical because, with the responsive neural stimulator, there have been 1 or 2 papers looking at children less than 12 for these electrical storms or electrical seizures that have no single foci. In this recent paper, that, looking at the use of invasive EEG in children 3 years and under, and they really found that there was a role with a minimal increased risk as compared to the older children and or adults. Looking at the types of surgery that can be done in these young children, you can have the focal cortical resection, such as cortical dysplasia tumors, less likely the mesial temporal sclerosis. Hemispherectomy is probably one of the more common forms, whether it be for megalencephaly, Rasmussen's, cortical dysplasias, or even infantile strokes. Corpus callosotomy, and more laser interstitial therapy is being instituted in the United States for these younger children. So before going to surgery, really recommend the role of the multidisciplinary team in helping predict and manage these children, and that would include the neurosurgeon, neurologist, neuropsychologist, radiologist, as well as the researchers for advanced technology, and a mutual decision is reached for the best solution, unlike these, this illustration here. So I think, in children, it's really the focal cortical dysplasias is probably the most common, and it's been reported as second most common type of seizure etiology. In non-eloquent cortex, it can be resected after mapping via grid or depth electrodes. Sometimes, not in these young infants, but in older children, awake craniotomies if it's close. And you can see here that originally identified in 1971, it really involves the lamination of the cortex and a significant loss. And looking at this paper and the seizure control rate, really what you can see is if there's a complete resection, you can achieve close to almost 3/4 seizure-free rate. If it's partial, it's 20%, and sometimes it's not visible on the MRI, or it's located near the eloquent cortex. And I think there is a role for depth electrodes in helping map these cortical dysplasias. The other surgery in these young children is hemispherectomy. And it's really, it's been for the treatment of unilateral hemispheric surgery, well described, first published in 1928 for a glioma in an adult by Walter Dandy, and however, further modified really by Crucknow in 1950, described it for infantile hemiplegia and had significant improvement in both the motor and cognitive improvement, and recommended the en bloc. And then Rasmussen in 1973 introduced the functional hemispherectomy, and Northfield, however, said, really, it's a pity that we abandoned the anatomical, but there's still a role for it. Here's an example of a young 2.5-year-old girl who presented with seizures at 1 year of age that started with staring and posturing in the left arm. Currently, when this would be in May of this year, she was having staring spells that were 2 to 3 times per day. It's very short-lived. However, she's having drop episodes with left arm extension as well as lower extremity, and that was about 12 to 24 episodes each day, as well as some partialis continua involving the left side. You can see the medications. She's on 4 medications, and she's already failed another 3 prior to that, and was developing regression. The MRI in November and the most recent MRI before surgery, you can see the development of further brain atrophy on that right side, increased ventricular size. The diagnosis was Rasmussen's. She was treated with IVIG and no luck. So she was brought to the operating room, and the plan was for an anatomical hemispherectomy rather than hemispherotomy or a functional, given the presumed diagnosis of Rasmussen's. You can see the brain at the time of surgery, after opening, and after the resection of that hemisphere. So and here's her post-operative images. Looking at her now, she, according to the mother who I just saw about 2 weeks ago, she's about 6 months out of surgery. She is seizure-free and on 1 medication. So this is the best she's ever been. She immediately had a hemiparesis and that has improved just with outpatient physical therapy. And the mother will state that this child is better than she's ever been for the past year and a half. And again, just hope the goal is to get her off her medications completely, but slowly. Looking at the seizure outcome in children with Rasmussen's, when you look at that, that the result of a hemispheric surgery or an anatomical is much better, statistically significant than if you're doing a less than complete approach. And this is a paper published this year out of the UCLA group, and looking at the angle seizure control rate. So the recommendations for the Rasmussen's really is the anatomical hemispherectomy. Looking at this paper from the Miami group, they looked at children that underwent surgery less than 1 year of age at their center for between 1994 and 2018. They identified 38 children, median age was 6 months, and they did it, as I had mentioned earlier, hemispherectomies, focal resections, as well as multi-lobar resections. And they found out that the mortality was 0, morbidity was about 10%, predominantly with infections as well as infarcts, but that the resolution of seizures was close to 70% in operating on these young children. And that even though these infants are so young, that the role of surgery remains safe, efficacious, and durable. And this is, looking at the paper, looking at the diagnoses as one would expect: cortical dysplasia, the Rasmussen's, and in several children there were some tumors that were identified in the control for seizures. And based on the resection, you can see that really, at 5 years, you had close to 68%, regardless of whether it's a focal resection, hemispherectomy, or multifocal, depending on the disease process in the children. They did review the literature and looked at this. Again, majority of these children, these young children, really are undergoing a hemispherectomy for either some congenital disease, whether it be a stroke, a migrational disorder, or Rasmussen's, and that the control rate is actually excellent, anywhere above 50 to 80% with surgery. Some of the other papers had a higher complication rate, but I think those were early in the experience. So I think, when I looked at the paper, looking at epilepsy surgery in the first 3 years of life, predictors of seizure freedom and cognitive development, as mentioned in these earlier studies, the majority of the surgeries, below over half, are hemispherotomies or hemispherectomies. 12 or 13% are multi-lobar, and about a third are lobar resections. And that a lot of these children had impaired cognitive developmental status before surgery, and that after surgery, that it was safe, and that the long-term seizure freedom and the cessation of anti-epileptic medications was excellent, and that the long-term cognitive development was excellent following early surgical intervention, as seen here. And you can see I apologize for this. My mouse is very sensitive. You can see the cognitive development before surgery as compared to the post-surgical development following surgery in that paper. So I think, again, just to close out, when we looked at looking at it across the world, in another paper looking at another 20 patients that had surgery at 9 months of age, that it was really the best developmental outcome was most evident in those young children that were seizure-free and off medication following the resection of their epilepsy focus. So again, more papers that recommend aggressive surgery for these children. And then finally, when looking at a new center and looking at their results, and this was just looking at their development of an evolution of a pediatric epilepsy surgery program over a 17-year period of time. Again, in Prague, and what they did see was that it does take some time, but over time, as the program matures, the seizure-free rate actually improves with more experience of the team as compared to earlier in the results. And then finally, just to close out the paper, really, this was looking at epilepsy surgery and the quality of life, and it was a retrospective review of close to 900 children, and that following epilepsy surgery, the children had a significantly improved quality of life, and that the children that had a total seizure freedom had actually improved quality of life as compared to the children that were still continuing to have seizures, and that the role of surgery is an effective way to provide meaningful improvements. And really, just to close, this is paper looking at the recent advances, and I recommend this for everyone, that it's a good review of all of the modalities that are available, including the neuromodulation. So I think to conclude, really, early resective surgery is very young children, is safe and effective, good seizure reduction, control with anti-epileptics, and preservation, if not improvement, of cognitive abilities. I think the multidisciplinary approach is critical, and that there's a low profile of surgical complications at experienced centers. So thank you for having me this morning or this afternoon to speak about the experience with epilepsy surgery.
Thank you, Professor Jello. It was an excellent talk, and I would like the panelists, Professor Manas, Dr. George, and Javane, to take over and discuss about both the talks. I see only a one question answer. I mean, I'm sure it's a difficult topic, so obviously we don't expect much question answers, I think. But nevertheless, could you just take over, George and Professor Manas?
Thank you very much, Professor Jallo and Professor KG, for that wonderful presentations, for sharing your experience straight from your heart. I'll set the ball rolling with a question which we got on the chat box. This is for Professor KG, Professor Koji Aida. This is the question is in the first and possibly the second patient, could we have done a single stage surgery as there was a clear MRI positive lesion without any significant discordance in the data? Could functional mapping have been done intraoperatively during the single stage resection? Professor Aida?
Yeah. I'm sorry.
Yeah, the speaker just wants to know if you could have gone ahead with a direct resection without an invasive EEG in both these patients.
In both case patients, yeah. And so a functional mapping we could not do in both patients, in either patient, because the patients were not cooperative. So when we stimulate on some channel or electrodes, but the patient would not reply to the stimulation. That's why the conventional functional mapping is not feasible in such an infant or very young children. That's why we need alternative way to get some motor function. That's why we did the SEP or MEP, like TO5, TO5. That was a very nice method to get motor response in the white matter. We can get some response in the brain surface, but the important thing is how to recognize the place very near to the pyramidal tract when we are detecting the lesion. So that's why I made a presentation about some ingenuity for functional mapping.
Thank you.
And,
Thank you very much. Thank you, Professor Koji. So the message I get is that invasive monitoring definitely, makes you on a stronger ground to fine tune your resection and to preserve maximum functional cortex.
Yeah, yeah,
So that's the message. Thank you so much.
yeah.
Another question. This is just from my side. In your experience with invasive EEG in children, what is the maximum number of grids or strips? That is the maximum number of contacts that you have placed. What is the maximum duration of placement that you've had in your experience?
Okay, so subdural grid or strip grid. And in adult patient, we have experienced the maximum of the 128 electrodes. It's a maximum of the EEG machine. Yeah, but if the capacity of the EEG machine is much bigger, we may do almost 200 channels of the electrode, but it cannot be done. And in infancy, the head is smaller than the adult. And usually the hemi one side. So probably 80 or 90 channels could be a maximum or infant. But in this presentation, I did 88 channels at the maximum.
And could I ask the same question to Professor Jallo, please? What's the maximum number of contacts and how long have you placed in children?
Again, I would say it's really the equipment needs, how many you can put in. We've done 140, 150 with a combination of grids and depths. The longest duration that I've kept them in is about 18 days.
Okay. I think the longest duration reported in literature is something like 42 days in adults. In children, I think it's around 25 days or something like that. So probably the less frequent seizures you have a risk of placing it for a longer time. Less the seizure burden and the frequency of seizures. We're still waiting for some more questions to come up.
I have one question. How commonly do you do bilateral implantations, sir? Because in pediatrics we have the problem of sometimes lateralization also, especially if the MRI is normal. So in that case, how many patients you would have done bilateral implantations? And how far is it successful in localizing the focus?
To me, okay. How many? I cannot say the precise number or percentage of the cases who shows MRI negative and bilateral implantation cases, but in the children, probably bilaterally implantation, I have not experienced bilateral implantation case in infants. In adult, it does often happen.
Yes.
Yes, and in pediatric cases, MRI negative, and there was no lateralization of the seizure foci using with preoperative evaluation. The most often method is corpus callositomy to get the lateralization of the seizure foci. This is our method.
So initially, you usually go ahead with calostomy followed by implantation. Okay.
Yeah, if they after the course of cardiotomy, if we can obtain some lateralization of the seizure, we can go to the next step.
What about tuberous sclerosis, sir? How is
Tuberous sclerosis. It's very difficult to localize the epileptogenic lesion. Cortical tuber, big size and with the calcification and the prominent tumor could be a primary epileptogenic lesion, but usually the patient has many tubers, which may be may have a potential epileptogenicity. So that's why usually the very difficult cases, very challenging cases for epilepsy surgery, particularly cortical resection. But we have some cases, we have experienced some cases who can be whose epileptogenic lesion could be localized by the MEG and some other modalities, then we reject such cortical tubers, then we could obtain the seizure freedom. But usually for TS cases, we do not do a grid implantation. Yeah, because of the lesion is there.
Yes.
Can I ask a question to Professor Ida?
Yeah.
And how do you you presented on combining depth electrode placement as well as grid electrode in children, but then in infancy it's difficult to fix the head. So how do you use navigation for placing depth electrodes in infancy?
Yes. So electrode of the for stereo EEG.
Yes.
We need a bolt, to fix the depth electrode. But when we combine the implantation of the subdural grid and depth electrodes, we've done the craniotomy. So the subdural grid can be, fixed with dura mater, and depth electrode is going out, through the dura. Then we can fix the dura mater.
No, my question was for using navigation.
Using navigation, yeah.
Navigation, you need to fix the head in a Mayfield clamp.
Yeah.
But then in children less than 1 year, it is difficult to do.
Yeah.
Then how do you use the navigation in those children?
Okay. So how to when we use the navigation system, we have to fix the head with the navigation system, right? And yes, there may be a risk of the movement during the surgery, but at that time the navigation system cannot be worked. But even though there is a risk of the movement, we fix the head bone is a forehead pin, very, very, how to say, weak pressure. The head may be moved. There's a risk of the navigation system, not working, but it's no way. There's no way. Because the children's head skull bone is very thin. Always risk of the bone fracture when we fix the head bone. We fix the head with very strong pressure of the pin.
Okay, I have one more question. Can I go ahead with the question?
Sure, sir.
Yeah, when you use an motor evoke potential, because it is, as you told, it is difficult to identify the motor cortex in extraoperative stimulation in children. During surgery, what stimulation parameters you use for adults and children when you to map the motor cortex?
Stimulator parameter. I'm sorry. I right now I forgot the precise parameters. I can email you about such one. And there is a report and a paper from the Hospital for Sick Children in Toronto, from Dr. Otsubo, already published a paper regarding the TO5. And in that paper, there is very details about the stimulation parameter.
Thank you, Professor Ida.
Thank you. I have a question for Professor Jallo. Professor Jallo, the world is divided between proponents of the vertical hemispherotomy and the other group who proponents of the horizontal Villemur's hemispherotomy. So as long as probably all the disconnections are achieved, they say that it doesn't matter what you choose. Do you feel that there is any particular indication which is a little more advantageous for the horizontal and similarly vice versa about the vertical?
No, I have no preference. I think the key is whatever the surgeon, you as the surgeon, is comfortable doing in achieving a complete disconnection. I think I have no preference or feelings that one is preferable to the other.
Thank you.
Yeah, the case which you have showed, Professor Jallo, you seem to have done an anatomic one, right?
Yes, it was Rasmussen. So I think for the Rasmussen, you have to do an anatomical. Otherwise, if it's not Rasmussen's, I tend to do the horizontal hemispherotomy approach.
Professor Jayala, can I ask a question to you?
Sure.
What percentage of your children go for invasive monitoring as compared to the adult patients?
I think more and more of the children we're doing invasive monitoring for if they have non-lesional epilepsy that's not visible, that's not a tumor. And the reason for that is we recently have the ROSA, a stereo EEG, and we feel that's pretty benign and less invasive than a craniotomy. So we'll insert anywhere from 9 to 20 electrodes, and we will do bilateral in some children at the same time, and monitor them before we proceed with surgery. So I'd say a couple of years ago, before the ROSA, we weren't doing as much invasive monitoring. With the ROSA, we're monitoring more and more children these days.
So we need more invasive monitoring in children as compared to adults, what I understand. The percentage.
Yeah, correct. Yes, absolutely.
Yeah, the same question. I will repeat what I asked Professor Ida, because when one uses ROSA robo, the head has to be fixed, fixed very well. Otherwise, the navigation, the planning is not so good. How do you do it for children, means infants, less than 1 year?
I'm sorry, I have not experienced the ROSA robot so far.
Yeah,
So,
Professor Jan, how do you?
So again, we are able to put them in an Lexcel frame, and the robot will support the head, and really the frame, the Lexcel frame, with the pins, you're able to hold it in. Is it do you want? Would I hold the head with that frame? No, but the frame is secured enough to the head, and the head is secured to the robot, and there's a buttress underneath where the head's resting, that you're able to do it with very good accuracy.
okay.
Professor Jallo, a short question for you. A lot of people feel that the term MRI negative for infants is a little bit of a misnomer because of their unmyelinated tracks. And what is MRI negative today, 2 years later might be a very focal, well-defined cortical dysplasia or maybe a malformation of cortical development. So how often, if you have a focal epilepsy in a child, what would be the frequency of MRI imaging you would advise in your practice, in your experience?
So no, and I agree. I think the issue is and we've had several cases here where the first MRI was negative, but over time, as you mentioned, with the myelination, that some cortical dysplasia does appear, and in retrospect was visible, was present on the first MRI, but you wouldn't know until you had the subsequent MRIs. I think I would scan them at least annually. The other option is to do a MEG for some of these children to see if you can try to localize it, or even sometimes it's a PET scan, so you can try to identify a focus and then focus the MRI towards that area, the abnormality there.
Thank you. Yeah, Suchanda, you had a question.
I just asked a question. I just wanted to know, what's the delay in place from diagnosing a person which is infant which is drug refractory to putting up on the operation table? Like, do you see there a lot of cooperation on the parents' part, or still, it gets delayed because people are still not ready for surgery?
Personally, I think they're still delayed. I mean, we've had delays of 2, maybe 3 years in some of these children to proceed with surgery.
What I understood from Professor Jallo is that in Johns Hopkins, perhaps in your practice, 90% of invasive for children is stereo EEG, while 10% is subdural. And perhaps in Professor Aida's practice, it's the other way around, 90 subdural and 10% stereo EEG. So my question to both of you is that, Professor Jallo, what is that indication which you feel where your first choice would be a subdural? And for Professor Aida, what is that indication in a child where your first choice would undoubtedly be a stereo EEG? Professor Jallo,
Yeah,
perhaps.
yes. I had a paper regarding the indication of the stereo EEG and subdural conventional chronic EEG. And for stereo EEG has many advantage for epileptogenic localization. For example, a deep-seated epileptogenicity suspected, subdural grid cannot reach, and we can get some neural network by the 3-dimensional depth insertion, and where the seizure is started and spreading in this way, that way, and we can obtain such a network. Then we can decide the rejection area. Theoretically, I studied, but I have not experienced the actual stereo EEG. I combine the subdural electrode implantation with additional depth electrodes. Five depth electrodes, and stereo EEG deep-sighted, and we can obtain the neural network. For subdural grid implantation, the most important thing is functional mapping. Very close to the eloquent cortex, probably we will do the subdural grid, even though the stereo EEG gets a popular methodology later.
Professor Jallo, your indication for subdural in this era?
So I think, as Professor Aida said, I think the role for subdural grids is really the eloquent or functional area. If you want to map, we get better mapping with speech, and maybe motor with the subdural grids as compared to the stereo EEG. So that would be the indication for us.
Thank you.
So we had a good discussion on this. I request Professor Manas sir to present your case.
Let George do it, no? First.
George, then.
Okay. I think the topic has been so fascinatingly and extensively covered. There's just nothing much that I can add to it, but I'll just share a couple of very simple cases. Can you see my screen?
Yeah.
Yeah. So this is just as perspective from a little different angle. So if you go for any pediatric conference, this is how most of the slides start, by saying that children are not little adults. Now, I don't think we should agree completely with this statement, because there is a lot of things which are different about children, like the unique pathophysiology of seizures, the functional plasticity. But at the same time, there are many concepts in epileptogenicity, the epileptogenic zone, the network, which are still similar to adults in many aspects. So this is something which we should only agree partially upon. I'll discuss an interesting case. Not too much the case as such. This is a 1-year-old child whom we operated about 5 years ago. He presented to us with an unremarkable perinatal history and milestones, facial twitching, and focal motor seizures. Epilepsia partialis continua with generalization. The clinical diagnosis, of course, without doubt, is the Rasmussen's encephalitis. This is how his EEG looked like. Right focal, right hemispheric spikes, which also some sort of spikes were originating from the left side as well. So we went ahead and we did a vertical parasagittal Dale-Landis functional hemispherotomy. We haven't done too much of an anatomical in Rasmussen's. Definitely, it's we consider it only when our functional hemispherotomy fails. But the point I get from Professor Jallo is that when functional hemispherotomy fails, anatomical is the next way forward for Rasmussen's. So this is what we did. We left a ventricular drain, and just as we, 3 years down the line, the child was completely seizure free, doing well, recovered well, gained all his lost milestones, almost started kindergarten school. And when we were just about to, blow the victory trumpet, this is how the child came to us. And this time he presented to us with no headache. He just had recurrent vomiting, and the scan looked like something like this. So I'm sure that all of us are aware that about 3 to 8% of post hemispherotomy hydrocephalus is something which stings you at the back when you're just about to celebrate your good results of a hemispherotomy. And we did a VP shunt on the left side, and then the child's vomiting subsided. And a year later, he presented again to us with shunt malfunction, and we had to revise the shunt. This time, we didn't have too much of economic constraints because of a government-funded scheme, and this time we put a programmable ventriculoperitoneal Codman shunt, and he did well. It's 1 year for follow-up after the second shunt, and he's done extremely well. So post hemispherotomy hydrocephalus, a rare complication. It could present almost acutely or delayed, and it could present with raised ICP, sometimes not the classical way with just vomiting, or it could even present with a new onset seizures of a different semiology. And there are a lot of papers in literature. A large meta-analysis and including our own experience says that the risk factors are the extent of resection, more so in an anatomical hemispherotomy, less so in a functional hemispherotomy. Intraventricular blood, the presence of post-operative meningitis. Surprisingly, there's no correlation with the age of the patient and also with the pathology. It doesn't matter whether you're doing it for a hemimeg or Rasmussen's encephalitis. So this is another an interesting case. So this is a 14-month-old female who presented to us with drug-resistant seizures, and a scan like this, is always worrying in a child because it could be just about anything. So just because of this drug-resistant seizures, we probably put our money on a DNET or a ganglioglioma. That is a long-term epilepsy-associated tumor. The new terminology is LEATS, and definitely, there is no second thought about going in for a surgery, both from an oncological perspective, from getting a tissue diagnosis, as well as from the seizure outcome perspective. So this was the EEG which showed right focal spikes quite well, well in concordance with the lesion. And lo behold, when we opened, we were really surprised. This is actually a cystic a cavernoma, and it made us feel happy because definitely the prognosis is better than for LEATS, that is long-term epilepsy-associated tumors. And in cavernomas, always the basic principle is that go a little beyond the lesion. An extended lesionectomy, which involves even the hemosidrin ring, the calcified deposits. This is the histology which showed so many ferruginized vessels. We have special stains, the Pearl stain, and a schematic representation would suggest that we need to take not just the lesion, we need to take the hemosidrin deposit and also the cortical dysplasia, which surrounds these highly seizurogenic lesions. So this is another child where I would just, I'm just showing you this to present a point about maximum tolerable blood loss. This is a 4-month-old child who presented with a hemimeg, almost a hemispheric typical epilepsy. This is the post-operative where we did again a vertical parasagittal craniotomy and vertical hemispherotomy. So when we are operating on children, what we need to be worried about is the maximum tolerable blood loss, because I'm sure all of us in pediatric neurosurgery have had those very low moments in life where we have had the devastating complication of a death on table. And when it's a child, a toddler, an infant with a curable problem, I think it never leaves your mind for a very, very long time. So So hence, all of us need to remember that when we have a small child, every RBC is very, very, very precious. And what we need to understand is to calculate something like, at least make a rough calculation in your mind of the maximum allowable blood loss. And how you do that is, this is how you calculate the estimated blood volume. In a child, it's around 80 to, in an infant, 80 to 85 ml per kg. So for a 5 kg infant, the total blood volume would be about 400 ml, and the maximum allowable blood loss, which is usually something like a blood loss over a period of an hour. Now, if the blood loss is more acute, I think it will be even, the allowable blood loss would be even lesser than this. If you're going to lose 50 ml of blood in about say a minute's time, that's significant. So the maximum allowable blood loss is not just a volume as it is calculated here, it's also the rate at which you're losing blood and the rate at which your strong anesthesia team is able to replace that. So always when you have this, you have to weigh the risks versus the benefits in pediatric epilepsy surgery. That is when this surgical candidacy message would always help you. A message by a very well-known and experienced pediatric epilepsy surgeon, Dr. Gary Mathern, who has said that no age, weight, or size is too small for epilepsy surgery if the seizure burden so demands. Thank you very much.
Thank you, George, for the demonstration of these cases. And so, I mean, you want to know a huge number of cases. So, what are the complications like you have shown in children? No, that hydrocephalus. What do you see the incidence of this at present?
Yeah, hydrocephalus post hemispherotomy reported in literature, and in our series of patients where we have about 4 cases in a number of about 200, which we have done in the last 5 years. So I think that the incidence reported in literature is at about 3 to 10%. There is a little bit of difference in the practice of epilepsy surgery in India. Unfortunately, since very few surgeons are in this field of epilepsy surgery, we don't have very purely devoted pediatric epilepsy surgeons as in the West, like Professor Jallo's practice, where he's a fully committed pediatric epilepsy surgeon. So here, most of us handle both adult and pediatric epilepsy surgery. And definitely, when you are more subspecialized, your results, your volumes are higher, and you definitely tend to do better. And hopefully a day will come when we have pediatric epilepsy surgeons in India as well. Thank you.
Jabin, you have any comments for these cases?
In our experience of hemispherotomy, what we have seen is that people who have bilateral damage with more obvious damage on the one hemisphere, they sometimes tend to have recurrences. But sometimes that damage is not very much obvious on the MRI. So what's your experience regarding this? I would like to ask Dr. George.
Definitely, I think one of the prerequisites for a good result in epilepsy in hemispherotomy is to have an absolutely normal, both functionally, morphologically, and electrically normal opposite hemisphere. So we probably also need to do a WADA test, and other than your usual imaging to confirm that. But then there are a few borderline situations where perhaps you never know till you operate and you see your results. So you have to take a chance sometimes. We've had patients who've had features of bilateral Rasmussens, which is very uncommon. But then, though you're not able to cure, you've been able to achieve, say, a significant seizure outcome benefit, maybe about 70 to 80%, which is still some form of benefit. So even if you can't cure, you can at least care for and give them some form of a palliative benefit.
We had one child with actually he was actually 13-year-old child with Rasmussen's, and he came to us with status epilepticus. And even though we had to operate him during the status, post-operatively for 1 week he improved, but later on he had seizures starting from the opposite hemisphere, and we could not do anything about it. Actually, he succumbed. So that was a very unusual experience of the opposite hemisphere producing seizures in an acute setting.
So we also had this situation where we had bilateral Rasmussens, but all the time we always review our diagnosis and think of any other forms of encephalitis which we probably could have missed. So that is something which we need to keep in mind as a differential diagnosis.
Professor Jello, what's the status of WADA now at your place? Do you still do, or it's completely now based on MRI?
We have shifted away from WADAs in the past 2 years. Everything's based on MRI. It's I'd say I think we've only done one WADA in the last 2 years, and that was really in a adolescent for mapping prior to surgery. But short of that, everything's on MRI, functional MRI, or MEG data.
What's the youngest child you've done a functional MRI, Professor Jallo?
The youngest functional MR we've done it. We've been able to get away with the functional MR in a 4-year-old child. But again, that is the exception. But you know, we work with them. Our child life team works with them and gets them prepared for the MRI, and we've been able to do it.
Okay. Any special precautions? How do they? Because children don't cooperate inside the MRI. How do you plan and do it?
You know, we set them up. We have a model of the MRI machine, and we have them go in there with our child life team, where they talk with the children and try to explain everything that's going to happen. So on the day of the MRI, they're prepared. Now we'll say, you know, yes, we got away with it in a 4-year-old. It's not easy though.
So if there's no other questions, sir, we would like to have your please.
Can I present?
Yeah, that's what I'm saying.
Sujana, can I present my case?
Yes, yes.
George, can you please stop sharing so that I share my screen?
Sorry.
George, you have to stop sharing.
Yeah,
then
I'm doing it, sir. Just a minute. Just okay.
Yeah.
We don't see your screen yet.
Can you see now?
Yes, we can.
Okay. This is a case which is not operated, so I'm presenting it for opinion. So I'll request Professor Jallo, Professor Ida, and all panelists, Dr. George and Dr. Jabin, Dr. Suchanda also to comment on what has to be done. This is a 2-year-old, 4-month-year-old boy, ambidextrous, non-consanguineous parentage, had full-term normal delivery, no perinatal complications, and had normal motor milestones normal, but then language regression is there for the last 4 months. There is no history of any febrile seizure. Family history, past medical history was not significant. Age of onset of the habitual seizure is 1 year, 8 months. And at present, he has hyperactivity and neurologically is inattentive and but he doesn't have any focal, cranial or motor deficit. Predominantly, the seizures are in the daytime. There are no precipitating factor, and it's a focal onset hypomotor seizure, and he gets 5 to 20 per day. And this is the video of the child. Starts with the staring and followed by posturing of the right upper limb. Has left hand autonomous automatisms with oro-elementary automatisms, prolonged staring. You can see the video.
Yes, we do.
Yeah, and followed by head drop. Yeah, as we have a lot of residents in the audience, I'll request Dr. Jabin to explain the localization from the video. Dr. Jabin, can you please help me?
Sir,
Jabin,
yeah. Actually, the video was not very smooth, but what we can find out is that there is a relative paucity of the right hand movement. I'm not sure whether there is a posturing. There is a relative paucity of the right hand movement. There were staring looks, and left hand was relatively free, and it was followed by a atonic drop of the head and neck. Usually, the problem in the pediatric epilepsy is that the manifestations are more generalized, and usually they are more atonic as atonic and tonic seizures which come into the picture, and atonic and tonic seizures usually both result in falls and injuries. So based on this EEG, based on the semiology, there is only one point of lateralization, that is the relative posturing of the right upper.
Okay.
So how many seizures were recorded, sir?
I'm not sure how many they recorded.
Okay.
I didn't ask that. But this
all were of same semiology,
all were of like this only.
Yeah, that's very important again, because if you are dealing with a single focus, it's very important that all seizures usually they behave in the same way. They are stereotyped, and they have all come from the single focus.
Yeah, all are stereotyped, and means as a presenter, no, all of them are similar type.
Yes.
And he's been on 5 anticonvulsants: lacosamide, clobazam, and phenobarbital, valproate, and lamotrigine. And in spite of that, he is to get 5 to 20 seizures per day. Developmental milestones on developmental screening, his quotient was 35, and social maturity was 9 months, at the age of 9 months, and so impression was disability on developmental and social maturity. And this was the interictal EEG, showing the spikes in the frontal and the temporal on the left side, as you discussed. And there is again interictal showing spikes on the left frontal and temporal. And this was the MRI. MRI, as Professor Jallo was discussing, that in children, because of less of demyelination, many times we find normal, and invasive monitoring like stereo EEG or subdural is almost to the extent of 5 to 10% in children as compared to 3 to 5% in adults. So the MRI was reported as normal, and even we also did not find any significant changes until the PET scan was done. In the interictal PET, there was hypoperfusion in the temporal region and hypoperfusion in the medial frontal. So when PET and so again same thing, an interictal, in addition to PET scan, we had an interictal PET, as already shown, discussed, temporal hypometabolism in the temporal as well as the medial frontal. We had an interictal spect. Okay. Then we had a PET and MR fusion done. After fusion was done, we thought there is that the temporal region, there is some hyperintensity in the temporal or probably FCD, because there is no gray-white matter distinction in this area. It is only after MR PET fusion, it was a retrospective MRI diagnosis. So you can see here that this hyperintensity corresponding to the hypometabolism in the PET scan. This is the ictal spect. In the ictal spect, there is left temporal hyperperfusion, which again was localizing to the left side, like what we saw in the PET scan. This is again ictal spect having hypermetabolism on the left side. So this is the summary of the hypothesis. The right-handed child seizure symbology was suggestive of prolonged hypomotor seizure with elementary automatism, suggestive of temporal left temporal, likely neocortical with uncertain lateralization, and interictal discharge from the left anterior and middle temporal foci. Ictal EEG also was suggestive of left anterior and middle and temporal. PET scan, FDG PET scan had left lateral temporal hypometabolism as well as mesial frontopolar area hypometabolism. And ictal spect showed only temporal. Now, the questions what I'll like to ask all of you is I'll ask comments from each one of you. Is it enough to plan surgery, and do we need further investigations, and what should be the surgical plan? Do a frontal, only temporal, or frontal and temporal? I'll start with Professor Jallo, and then Professor Ida, and then Dr. Jabin and Dr. George and Suchanda also. Dr. Suchanda. Professor Jallo.
So for us, or for me, really, I don't think I have enough data to suggest whether I'm going to do just a temporal or add a frontotemporal resection. I probably put depth electrodes in there to help identify better identify the electrical foci for the seizures. But I could, I could see some centers doing it without further, without the invasive monitoring.
Okay, so in your center, you would have gone for a stereo EEG for this child.
Yeah, absolutely. Yes, absolutely.
Yeah. Professor Ida? Professor Ida, are you online?
Yes, yes, is there. You are muted, Rania.
Yeah. Is this enough to plan surgery? Yeah, so we need, so we may go to MEG.
Okay.
So FDG and SPECT MRI was normal, and other modality suggests left front temporal region. And for me, the next investigation is MEG, because the patient had spikes over the left front temporal region. If the MEG shows some cluster region in some area, it's a very, very strong evidence of the epileptogenic region. So that's why that we can focus on the such area to cover to be covered by the subdural grid electrode.
Okay, means for MEG will be followed by subdural, or you feel that with MEG, if you get only temporarily, go ahead with the surgery?
MEG up for all?
MEG is enough, or it has to be followed by subdural grid placement in your center?
If the MEG shows some clusters.
Yes,
if inconclusive, it's not enough.
But if it's conclusive, then you don't have to go for a subdural.
Yeah.
Professor Jallo, can you come back? Like, if you have an MEG and a depth electrode in a 2-year-old child, what should be the preference, to go for MEG first or do a stereo EEG?
MEG first, and there's some if they have we have some cluster, or you put the subdural electrode surrounding the ear.
I think, if you can get an MEG, that'd be great. We only have one MEG in the whole state of Florida, and sometimes it's difficult to get access, or sometimes the insurance doesn't cover the cost. So I think if you get an MEG, great. If not, I would just go, for us, it's easier just to put in the subdural, the stereo EEG.
Okay. But in means if one has an access to MEG, MEG is a better option. You agree with?
Yes, absolutely. Correct. Yes.
Dr. George, and
so this is this, I think I'll have two answers, one for a developing country and one for the developed countries. So if this patient had to come to my center where we are practicing in a developing nation and economics is a problem, there's no doubt about the lateralization in this patient. It is definitely left side. Only thing that we need to do is to fine tune the localization. So if there were, it would be ideal theoretically to do an invasive monitoring. I wouldn't really prefer to do a MEG, because if there is some form of an added extra localization or a not so clear localization with MEG, I'm not sure if that would be an added advantage. So stereo EEG next, because a subdural in a 2-year-old child is definitely not practical in a center like ours, which is not programmed to invasive monitoring in small children. So a stereo EEG, which would help me to be 100% sure that it is the temporal, the left frontal, and what is the other most adjacent area would be the left parietal. So a stereo EEG with a sort of a coverage which involves the left frontal, left temporal, and left parietal would be ideal. But if economics is a constraint, I definitely wouldn't hesitate to take a chance, though perhaps it might be jumping the gun in the West or in a developed nation, to take a chance and go ahead with a multi-lobar resection involving the left frontal and the temporal lobe. Overdoing it a little bit at the first stage, definitely ensuring that the patient is functionally intact, and plasticity would help him to get further better as he grows up. So my choice would be definitely an upfront resection if there is a constraint for a stereo EEG.
So if you plan stereo EEG, this is a 2-year child, whether you'll do a frame-based or a frameless stereo EEG, because in children, as you know, it is difficult to fix a frame like cell frame or a CRW frame.
Right.
So how, that's what I've been asking Professor Ida and Professor Jala also, because the accuracy with the frameless, suppose you use a EM technology for the navigation, the head skull is not fixed so well. And so how do you plan to do stereo EEG, frame-based, frameless, is it optical-based or electromagnetic-based?
We perhaps would, a frame based would be a little difficult sometimes. So we would probably try to use image guidance and do it frameless with either Brain Lab or the Medtronic's image guidance.
Yeah, but that image guidance also you need to fix the head, is it not?
Yeah, we need
is
to
it enough?
That's right. Yeah, we need to fix the head. But
so what fixator you use for that you get a rigid fixation, or you use electromagnetic EM technology?
EM technology is an option, but our experience is more with using the pediatric pins and a Mayfield clamp, a rigid fixation.
Yeah, Dr. Jabin and Dr. Suchanda.
Sorry, in our setup, what we can do is we cannot do any stereo EEG because the number of electrodes will not be able to get it. Point number one. So that option goes out if I look at my local scenario. The option left with us is only a subdural bridge. So we can put a subdural, do the functional mapping, and then plan it out and then go and resect. I would plan it that way.
I'll just interrupt Suchanda. by stereo EEG, I do not mean that you do it the ideal way as the French and the Europeans do
Because
it.
freedom in gets compromised
Yeah,
because we don't have electrodes.
that's right. When we are constrained, we try to achieve maximum with minimum depth electrodes. So perhaps you use minimum electrodes, though many people, though the proponents of stereo EEG say that anything less than 5 electrodes perhaps may not be useful, and anything more than 15 would be probably a fishing expedition. So I think we just have a hypothesis in our mind, and then we sample bare minimum with the bare amount of money that we have.
George will also do the mapping also, no, for this case.
With
But yes,
then we'll,
the regression of language.
so
So
if we have to map, we probably need a mat, that is a grid. With a stereo EEG depth electrode, it would be a little difficult.
no, that's what I was thinking, because the language is affected here. No, already affected, right?
Yeah, yes.
But when we have a very clear electrographic localization and a very not too much of a doubt with the lateralization based on your PET and your ictal spect, I think we definitely should give this child a chance of a resective surgery. Though perhaps theoretically, if you look at it, we need an additional investigation. We need some form of invasive, but we definitely shouldn't deny this child a chance of a probable cure.
Yeah, Dr. Jabin.
Sir, I would actually review the MRI and see whether the MRI lesion is well defined. If it is not well defined, I would definitely like to do invasive only in this patient, because the amount of resection involved is quite uh, huge, and it is also on the dominant side. So I definitely like to do invasive monitoring before going ahead with surgery, because the MRI lesion is not very well defined. If there is a clear-cut anterior temporal polar dysplasia, then probably doing only temporal resection would be the best option.
Yeah, with MR and PET fusion, there is I mean, then he can find a lesion in the temporal.
Yeah,
So
because
just
doing frontotemporal resection on the left side will be a very huge resection. It may completely damage the child's IQ.
We could
this
spare
child,
we could perhaps spare anatomically the Broca's and the vernix areas. So your resection would be short of anatomical functional areas, though functionally it might have shifted. And then we also are we are also capitalizing on the concept of plasticity probably taking over, because the cumulative outcome of this high seizure burden would be too difficult to bear for any further years of his life, of the child's life.
No. The problem with the Dr. George is that these type 1 dysplasias, they are quite extensive.
I understand. Yeah, I understand.
What they have seen on the MRI may be just the tip of the iceberg.
That's right.
So you start resecting one part, they will start firing from the other part.
That's
So
right.
without a invasive monitoring and without exactly localizing the origin of the epileptogenic focus, it becomes very difficult to assume that the patient will become seizure.
but this one like has a hypometabolism is a medial frontal, and left temporal
So that
is
is part of the network, or whether there is a dysplasia involving both the lobes, we are not sure.
yeah, but PET is positive, SPECT is positive. Clinically, it is left, and is it? I'll ask an opinion whether is it cheaper to just to do the temporal and plan that frontal means invasive monitoring or frontal later if required, because many times here temporal will be enough. After suppose MEG shows temporal, you do temporal only, is it not?
Yes, sir. That's why probably MEG may help. Like if MEG, if it shows only temporal polar dipoles, probably you will be more confident in going ahead with the surgery.
Okay.
Can I ask a
So
question?
yeah.
2 years in this state, like, how can we, like, we are talking about brain's plasticity and all, but is there a way where we can say that, okay, we know that this child will recover in functionality even if we resect? That's like, it's a gambling. Some may do, some may not do, but functional MRI, like as I was asking earlier, functional MRI for a 2-year-old again is a difficult thing, right? And
Yes.
whether we are taking a big chance on just depending on brain plasticity. So what is the way forward? I just wanted to know in these small children. When they are able to do and cooperate, that's a different story. But yeah.
You are asking Professor Jallo, or
I'm asking everyone, whoever gives the answer.
we'll start with Professor Jallo then.
Honestly, in certain parts of the world, correct, that don't have the resources, they would probably proceed with the temporal lobectomy. And as you said, Sushanda, just see how the child recovers and see how the seizures do, and then be prepared to bring them back. I mean, there are many places that don't have the resources to invasive monitoring, MEG, or any of the other data. And I still, especially in children, I see no reason not to operate and try to give this child a chance, albeit not a comprehensive, approach.
Professor Ida?
Yeah, so that's why. So from this result, you have already obtained. So my plan is coverage by the subdural grid of left frontal temporal and the combined depth electrode into the major temporal hippocampus and amygdala. A strip electrode could be inserted to the basal frontal, major frontal, and the basal temporal. But MEG could be option to get some localizing value. If the temporal lobe or frontal lobe, anyway, any place is okay. There's if we get some dipoles sources area, it's a very strong key of the epileptogenic focus. This is my idea.
Okay, thank you. So, what I understand from all the PAM members that the first option, if available, it's a non-invasive MEG, and if MEG is conclusive, we can go for surgery. But if it's inconclusive, to do invasive monitoring, either stereo EEG or subdural electrode with depth electrodes placement, and then plan the surgery. Do all of you agree with that?
Yes.
Okay. So Dr. Suchanda, you can, if there are any other questions from the audience, you can ask, because we have only 10 minutes left, I think.
Yeah, I think there are a few questions. I'll just read it out.
Yes.
One of the questions is that in clinical semiology, is not head and eye turning to the left suggestive of a right-sided lesion? Perhaps Professor Jabin can take this question.
Can you just repeat?
In clinical semiology, is it not the head and eye turning to the left suggestive of a right-sided lesion?
It's actually the head and eye deviation can be ipsilateral or contralateral. If it is a forced head and eye deviation or forced head and eye deviation before secondary generalization, then it is contralateral localization. So if it is a non-forced eye and head deviation, then it can be ipsilateral.
Right. I hope that answers the question. And another comment by Professor Mazumdar. Professor Dattarai Mazumdar is a very well experienced pediatric epilepsy surgeon working at KEM Hospital, Mumbai. Professor Mazumdar says that without invasive monitoring, diffuse FCD surgery would be difficult. I think Professor Mazumdar is referring to the case that Manas presented. So we've got an additional viewpoint is that invasive monitoring, an additional person supporting our views here, saying that invasive monitoring is definitely the way forward with that case. I don't see any other questions.
I wanted to know, like head turning, how much weight do we give that in infancy, and this one, keeping in mind about myelination factor, which it doesn't, which is immature. This head turning and all, are there very this one?
Yeah, actually, all the studies which have been done regarding the sensitivity and specificity of these signs, they are mainly in the adult population. So how much we can apply it to the pediatric population is a very difficult question.
Even hemiparesis is also doubtful, no? How much they reflect in infants and this one.
Hemiparesis?
Yeah, even that, because of that, I was just seeing that.
Regarding the plasticity.
Maturation of the things, we cannot exactly.
Yeah. No. Hemiparesis is usually contralated to the side of vision. But the EEG wise, sometimes if you have a severe damage to one hemisphere, you can have false lateralization of the EEG to the opposite hemisphere. That is very well known.
One more thing, see, we look for hemianopsia and all this. How do you do in 1 year and 2 years? Yeah? What do you look for it?
Yeah. That is again a very difficult question. There is we need expert from ophthalmology in that case. And I heard that there is one lady in LV Prasad who is helping us with very young patients whom we want to detect hemianopia.
Any gaze preference or something like that, maybe.
Yes.
So if there are...
Maybe we can ask this, Professor Jalo can help us in answering this question about how to detect hemianopia in infants and toddlers.
I just don't think we can, honestly. I mean, there's visual evoked potentials in monitoring. I don't think
we do that hemianopic stimulation and try to record the VEPs sometimes. But
So I think we are almost nearing time, right? So,
yes.
Yeah, Suchanda, before you end, can I ask you one question?
Yeah.
Now, taking this a little forward than this webinar, is there some way that all the pediatric epilepsy surgeons who are part of this webinar and also the others could pool in their experience together as part of the Indian Society of Pediatric Neurosurgery, and pooling in our experience and doing something collaborative? I think probably we could work on this.
Discuss about that and look forward to it. Otherwise, as it is, you can see, I mean, compared to other webinars, because epilepsy surgery is still developing, right? And then I have taken a topic which is infants, and this one, which I felt is very difficult. People doesn't talk about it in our usual epilepsy conferences. They're only talking on temporal, extratemporal, and this. So that was the reason we thought that we should look to all these things, because there are questions now. People come and we need to do early, right? So that was the idea of getting the infancy and toddlers today's picture. And I think definitely we should all collaborate and see that network is formed, and we can go ahead further with a better program, so that we have no dearth of patients. Only thing is that we have dearth of resources and, what I want to say, that time from everywhere so that we can do some academic and research. That is the problem. So I'll take your suggestion, put forward in the society also in the next meeting, so that we can see that something happens there as well. So I think I would like to thank Professor Ida and Professor Jello for giving your valuable time, and we had a good discussion and a learning, and we hope to get your participation and cooperation in the future as well for other conferences or webinar as it may turn up. We don't know when we'll have a conference now, but as of now, it's just a webinar which is going on. And thank you, Professor Manas sir, George, and Javin for being there. And thanks all the participants who were here. And this was a specialized group, so obviously the participants, we did not expect a very high percent participants, because not very significant number of people are doing epilepsy surgery in this country as of now. So with this, I thank once again all of you. Have a wonderful day, wonderful evening, and with that I conclude. Thanks once again. Thank you all.
Thank you so much.
Thank you all. Have a good day. Bye-bye.
Thank you. Thank you.
Thank you, all of you.
Good night, Professor
Have a
Ida.
nice sleep.
Good night.
Good night.
Good night.